talking about supportive care in kidney in ALA amyloidosis. I'm Lluis Quintana from the hospital clinic in Barcelona. I have nothing to disclose for this talk. So I will start to say that kidney is the most frequently involved organ in systemic amyloidosis. And this is clear for the acquired amyloidosis, ALA amyloidosis, A amyloidosis, or leg 2 amyloidosis, and also for hereditary amyloidosis. The pattern and severity of renal manifestations vary according to the involved amyloid precursor. And that's important when we talk about ALA amyloidosis. Usually, when kidney is involved in ALA amyloidosis, the patient presents proteinuria. And this proteinuria could be asymptomatic and also would be symptomatic. When it's symptomatic, we are talking about a nephrotic syndrome that is characterized by edema, hypoluminemia, and hypercholesterolemia. Less frequently, the patients with amyloidosis debut with renal failure and progressing to end-stage renal disease. And it's rare other presentation as we see in the slide. One of the important concepts that I want to communicate to you is that, of course, kidney are involved in the disease because kidneys are affected by this extracellular deposition and have structural damage. But also it's important to understand when we talk about kidneys in amyloidosis, there are also toxicity related with the proteinuria and other damage related with extrarenal manifestation. Very important, the heart manifestations, but also gastrointestinal liver manifestations affect, for example, treatment response in the case of renal amyloidosis. Another important thing is that it's a complex disease, and many times we have merging etiologies in a same patient. And this is important to know. For the doctors, it's a challenge to diagnose this disease, and also now we know that we have many causes of amyloidosis. And for example, up to 10% of the patients with hereditary amyloidosis also have a monoclonal gammopathy on clear significance. And more than 20% of the patients with A amyloidosis have monoclonal gammopathy. So sometimes it's really conflicted to know what's happening in a patient. For all the reasons, from the kidney perspective, it's very important to work as a team, work in a multidisciplinary approach. Because as you know, as we commented before, for the kidney manifestation, it's important the deposition of this amyloid protein in the kidney, but also it's important the extrarenal manifestations. So, of course, the management of renal amyloidosis relies on the suppression of the production of the amyloid precursor whenever it is possible. But it's also important to slow the progression of the disease in the kidney. And in the next few slides, I will try to explain how that is working on. So, one important concept is that when we have proteinuria because of the amyloidosis and we start treatment, sometimes the treatment response in the kidney lasts more time, can occur at any time from 3 to 18 months after the achievement of the hematological response. As you know, the disease starts in the bone marrow, but we can control the disease in the bone marrow and continue with symptoms in the kidney. And that's important in order to try to halt the progression of the disease in the kidneys. Usually, the creatinine, the serum creatinine, that is the biomarker that we use to measure the function of the kidneys, is normal at diagnosis, but that don't believe that can easily worsen. For example, for excessive depletion, for hypotension, for infections, or for the use of nephrotoxic agents during the treatment of this hematological disease. So, progression to end-stage kidney disease occurs in a variable proportion of these patients, ranging from 50 to 30%, according to different etiologies of the systemic amyloidosis. An important thing is to know how we try to predict the prognosis for the kidney in this ALA amyloidosis. We use proteinuria and you use eGFR, the glomerular filtrate rate. And we know that the patients that have more than 5 grams a day of proteinuria and less than 50 milliliters per minute of EGFR has the worst prognosis and has the risk of more than 60% to have kidney failure after 3 or 5 years of the evolution of the disease. An important issue is that the time from the debut to the hematological remission is an independent kidney prognostic factor. As soon as you achieve the hematological remission, the better prognosis for the kidney. And there are other prognostic factors that are more complex that the doctors use to look at to try to predict better the kidney outcome. One important concept is no matter what is the cause of the disease in the kidney, when you have nephropathy, when you have kidney disease, you have progression of the disease because of metabolic factors, hemodynamic factors, and these factors unit to the amyloid deposition cause fibrosis. Fibrosis is scars on the kidney. When you have scars on the kidney, it's peculiar, but the kidney triggers more inflammation. Scars on the kidney, no matter what is the cause of these scars, cause more inflammation and a vicious circle of inflammation and fibrosis. And even worse, if the patient has had amyloidosis and then gets diabetes, obesity, or hypertension. So we have to take up in account many variables, hemodynamic factors. We look at the podocytes as a complex network of cells in the kidney, and we now know how to halt the progression in early stages. This journal is really complex, but my message is we need to fight for an early diagnosis because we have good treatments to halt the progression when we are able to detect early the disease. Of course, we need to fight against the etiology of the disease, but there are so many supportive measures to avoid this chronic kidney disease that differs from the etiology of the disease. There are at least more important here, but one of the most outstanding biomarkers is proteinuria. Control of proteinuria is a major therapeutic objective aiming at improving renal outcomes in the long term. So, I said at the beginning that probably is not specific for the diagnosis, but is very useful for the follow-up. If you are able to control proteinuria, the disease is going better. And we have many treatments that could be used for other indications, cardiac disease, hypertension, but also are able to stop the proteinuria and helps the kidney to avoid end-stage renal disease. That is the case of renin-angiotensin system blockers, including ACE inhibitors and angiotensin receptor blockers that are frequently used to reduce this albuminuria. Although there is not evidence supporting their efficacy in amyloidosis, we use the experience in other nephropathies and we try to use these drugs in patients with amyloidosis. But we have to pay attention because these treatments should be avoided in patients with cardiac or autonomic nervous system involvement with hypotension. And we need to do careful surveillance to avoid the appearance of acute kidney injury or hyperkalemia. Moreover, we have other treatments, new treatments, that emerge as another tools to try to halt the progression in the kidney disease. One of these ones are the SGLT2 inhibitors. There are drugs that stimulate the elimination of sugar by the urine, and in that way decrease the pressure inside the kidney and reduce proteinuria. They reduce cardiovascular events even more, and they do this in a glucose-independent manner, and in that way could reduce mortality in patients with heart failure and kidney failure. That is the case of patients with amyloidosis. Another important thing that these new drugs reduce blood pressure, control uric acid levels, avoid fluid overload, and the risk of serious hyperkalemia because they cause reduce or enhance the excretion of potassium by the urine. So that is another positive effect. So these drugs could be particularly suitable for patients with concomitant renal and cardiac amyloid involvement. But we need prospective studies to precise the efficacy and the safety of these drugs in this setting. But it could be a promise, and we are using these drugs now in real clinical practice. Of course, supportive measures not only is a question of the doctor and a question of prognosis, it's also a question of comfort, because edema contributes to immobility, fatigue, discomfort, skin blistering, infections, and anxiety. So it's important to treat also to do comfort to the patient, to give comfort to the patient. The treatment is based on primarily the dietary sodium restriction and diuretics. And also, sometimes it's important to do water restriction, especially in the patients that are developing hyponatremia, decreased levels of sodium in the serum. In case of insufficient response, sometimes we can merge or use combined treatments with different diuretics, and we need to check, in this case, the electrolyte levels and potential adverse effects. So our treatments are complex and need a multidisciplinary approach. For the kidney, also are other variables that are important. One of these is when is indicated to do anticoagulation or prophylactic anticoagulation, because patients with amyloidosis that had serum albumin levels below 20 grams per liter should be considered, particularly in the presence of other risk factors of thrombotic events that are obesity, immobilization, recent surgery, or genetic conditions. Of course, we need to balance, because patients with amyloidosis also have potential risk of bleeding, and we need to carefully evaluate this, because it's important to establish if the patient bears a deficiency in coagulation factor. The most commonly is in factor 10. So, in patients with indication for prophylactic anticoagulation, we used to start treatment based on heparin, low molecular weight heparin. Warfarin may be considered for prolonged anticoagulation, targeting to INR of between 2 and 3, and frequent monitoring is mandatory in these cases. And now we have new oral anticoagulants that remains to be evaluated in patients with amyloidosis, but could be an option. For example, one interesting option is apixaban, because it has lowest renal elimination and can be used at adapted dose in subjects with chronic kidney disease. Even more, there are other important supportive measures that are important for kidney health in the patient with LA amyloidosis. Careful nutritional evaluation is important. Vaccination should be systematic. Antibiotic prophylaxis are required if you are under clone target therapy, of course. And for example, in patients with active nephrotic syndrome with edemas and hypolipidemia, it's also important to control lipids. The treatment of this dyslipidemia relies mainly on the prescriptions of statins. And finally, when we are not able to halt the progression and we have a kidney failure, we need to think about it, the renal replacement therapy. It's important to have a plan for this. Decision regarding renal replacement therapy should take into consideration different factors. First, the age. Second, the extension and severity of the extrarenal manifestation of the disease. And the more important factor, the eligibility for kidney transplantation. Both hemodialysis and peritoneal dialysis can be considered, and then in the next talk, you listen about this. But it's important to consider that kidney transplantation is the best way to replace kidney function whenever it's possible. So, the take-home messages are: renal responses are delayed and are related to the deposit of amyloid, but also for the chronicity, for the scars in the kidney. So, even if the most crucial factor is hematological response, it's very important to control the disease in the kidney. And it depends that other factors that we discussed before. Kidney supportive care improves treatment response and quality of life. And this is important to understand. Unfortunately, in early stages, the disease in the kidneys is silent. So we need to be aware of that, and we need to try to control, even if we have no symptoms. And for that approach, we require multiple injury mechanisms that could be simultaneously targeted. And especially important, the multidisciplinary approach. I think this is the effective collaboration between specialists, doctors, and nurses is the cornerstone to improve kidney and patient outcomes in patients with ALA amyloidosis. This is the organization chart of our unit in the Hospital Clinic of Barcelona, but behind a chart of organization are the people that fight to improve outcomes in the patients with renal amyloidosis. Thank you for all of the team, and thank you for your attention. I'm very sad that I cannot take questions because I need to go for the other session, but we can talk later in the lunchtime or in another coffee break. Thank you very much.